Any questions for IV inductions? It's too general, there's no questions can be asked. Okay, can we continue? Muscle relaxant. I'm tired, you're tired. Everyone's tired, lunch already. Okay, very fast, quickly go to the last part. Okay, I think you are not expecting all these things. We're expecting me to tell you, okay, for example, thiopental, now what is thiopental, how to use thiopental, what's the PK of thiopental, effects. Next, like that, isn't it? You never expect, you go to receptors, you know about receptors and things like that, but yes, this is what is expected in you. Pharmacology is not about the drug itself, but also the basics. Okay? Alright. So general objective, very simple. Again, you need to know the pharmacological properties of each of these agents, able to compare them and know what is the clinical implications of the comparisons. Right? A lot of specific objectives, and when we come to neuromuscular relaxants, wow, it's a very long story before we go to the drugs. Okay. So it's very good revisions for your neuromuscular junction actually. Okay, so first question, this is again Hausman questions. What is neuromuscular blocking agents? So you talk about it is the drug that used to produce striated muscle relaxations, but it doesn't work on the heart. Dr. Standard told you why, we just right? You know why? You know why it doesn't work on the heart? Because it has a pacemaker, right? Okay, during surgical anesthesia and act via a reversible inhibitions of the interactions between acetylcholine and also the post-synatic, post-junctional nicotinic acetylcholine receptors. Okay, makes sense to you? It makes sense, isn't it? If you take off any part of this, you change the definitions, then it doesn't make sense anymore. You try and see later. Some of you can make it shorter, okay? Alright. Anatomy and physiology of the neuromuscular junction. You need to know this as much as in physiology and pharmacology. We don't separate the two exams anymore, so yeah, no choice really. When you read about muscle relaxants, read about the NNJ as well. How details you want to know about NNJ, I'll tell you. You need to know very details as good as the physiologist. Right? Because you use these drugs and this is your drug. Nobody else in this world besides anesthetists can use muscle relaxant, decision. Okay. So you need to know very details from the alpha motor neuron, come out from the anterior cord of the spinal cord. It is myelinated, it forms a button at the terminal here. What is the content of this terminal nerve? Okay, you need to know that it's mitochondria and this and a lot quantum of acetylcholine. Alright? So okay, it forms a synapse, you have a synaptic cleft, and this is the active zone. And then the synaptic cleft for invaginations, and when you find the receptors at this side here, and then what are the receptors? It's called the nicotinic acetylcholine receptors. It has got the post-junctional and also the pre-junctional receptors. That's how details you need to go into it. And not only that, you only talk about the anatomy, okay? You talk about the physiology, when there's a transmissions, you talk about the transmissions of the action potential, reaching there, causing the calcium to be influxed into the membrane, and then it forms binds the carbon. I can go into that later. So we talk about acetylcholine synthesis also. Okay, are we there? So acetylcholine, it has got the acetyl group and also the choline group. Where do you get the choline from? Dietary plasma hydrolysis of the acetylcholine. Okay, contribute 50% of this. I'm not sure whether it can be asked or not. If I'm the examiner, I'll ask you very simple, 50%. Okay. Then how does this choline be taken up? This is very important. This SDHACU system, okay? SDHACU system. This is the one that takes up the choline into the cells, and then you have the this one, acetyl-O-methyl-transferase that combine the choline and also the acetyl group to become acetylcholine, and the choline recycled back to your Krebs cycle in the mitochondria. That's how you form acetylcholine. You need to know this? Yes, you need to know this. Okay. Then the acetylcholine is being stored in the vesicles into two pools, which is the reserve store and also the readily releasable store. Okay, so it's in the synthesize really, you store them into two pools. Need to know these two pools because later on you're going to talk a bit more when you answer exactly later. Okay, all right. So there you got the action potential, stimulates, activates the calcium channel, a calcium influx binds on the calmodulin. Okay, calmodulin will then activates these vesicles. The vesicles say, okay, I need to be going through a series of activity, which is mobilizations, docking, priming, stop there, and then it fuels exocytosis, protein and it binding and recycle. Release of the acetylcholine acts on the receptor, post-synaptic and also at the pre-synaptic receptors. And we'll go into that later. So this is how it is we're going to talk about it. Okay, then it goes back, right? Next is, sorry, talk about the receptor first before I go into the pre-synaptic and the post-synaptic. But remember that I'm going to talk about the pre-synaptic receptors later on, what is the function, okay? So nicotinic acetylcholine receptors is formed by different types of subunits based on where they are. So in the muscles, we have got this alpha, beta, delta, and depends on whether it is a fetal or is it a adult mature receptors. Right? If the adult receptors is by the epsilon group, if not, then it is by the gamma subunit. It has got 2 alpha, which is the active binding site of your acetylcholine. It needs to be bound both at the same time simultaneously for the activations of the receptor. Okay, this one you understand, right? I'm sure everyone understands this idea. Yeah, very good. Okay, pre-junctional nicotinic acetylcholine receptors have got 3 functions. Basically, I told you just now, right, why we need to know about the VP1, VP2, the readily release and also the store of the vesicles is because of this, right? Because it also acts, this nicotinic acetylcholine also acts on the pre-synaptic receptors, and then it regulates and mobilizes whether they want to release more of these vesicles or not, mobilize them to the active zone to be released readily, or they actually stop it from being released, right? It regulates. Also, the inhibitions of these receptors are causing fade. This is important because another question that commonly asked when asked about muscle relaxant is, how does fade occurs? Alright, especially those that are sitting for MCAI. Okay, how does fade occurs? It's because of this pre-junctional nicotinic acetylcholine receptors being blocked by muscle relaxant. Okay, so we talk about these 2 alpha subunits need to be activated at the same time in order to open up the receptor, isn't it? So we block one of the units enough to block the activity. Then also we go about this immature extrajunctional receptors, this Kakao and MEDEX in part 1 as well. So I told you just now, the fetal one or the immature one has got this gamma subunit. So when they become mature, it's actually replaced by the epsilon. But there are certain conditions where we have these extrajunctional receptors that actually got this gamma subunit. What are they? In patients with reduced activity, so big bowel patients because of stroke or whatsoever reasons, those with upper lower motor neuron lesions, spinal cord injury, burn, sepsis, and also other things that causes muscle protein breakdowns kind of thing. Okay, they will have a lot of extrajunctional receptors. I'm sure everybody knows already, and that's why we do use subtle returner in them because of this hyperkalemia, prolonged opening time. So you're expected to describe that just how everything from action potential down to the release of the acetylcholine, actions back to the pre-synaptic receptors. Don't shake your head lah, it's okay, you'll be able to tell me by the end of the talk. Okay. Alright. And then it stimulates the actions over the synaptic cleft. How is it being metabolized? Okay, it's metabolized by the choline esterase, hydrolyze and then recycle. That's why I talk about recycling. Okay, and then the actions after it stimulates the nicotinic acetylcholine receptors in the post-junctional area, it causes depolarizations. Depolarizations activates all your sodium channels. The sodium channels will then cause the muscle to contract. You need to be able to describe the excitations, relaxations, something. Okay. Can. I'm talking so much because you already know already. Because everyone of you already know how it works. It's just a revision. Okay. Something is asked in exam very frequently as well, either as an open-end question sometimes, or actually can be in the MCQ. What are the safety margins of the neuromuscular junction of neuromuscular transmissions? So basically, you ask you, what is the safety features that God made in you that make sure your muscle actually contract every time you have action potential? So you want to slap somebody, straight away you can do it. Okay. So, come in numbers again. Number 1 is, okay, just think of how the action potential was transmitted and cause of muscle contractions. Okay, it causes a lot of release, right? So the store, there's a lot of acetylcholine store, number 1. Okay, when it releases a lot, so much more than is required to generate muscle contractions. So number 2. Okay, number 3, there are a lot of receptors that are being activated at the same time, much more than is required to generate muscle contractions. Okay, number 4, the anatomy of it. Right, the anatomy shows that the synaptic cleft is very close, right? It's very small. the distance need to be traveled is very, very minimal. Okay, so it's one of the safety features, basically like safety features, and make sure you can scare somebody from the side. Just for example, you want to write answers during an exam, you can write it straight away. You won't have anything to stop you from doing that. And yeah, this one, actually this is not a very good picture. You can get better pictures where you see all these cross over the nerve transductions and things like that. There are other drugs that causes muscle relaxations besides your neuromuscular blocking agent. You know that? Some acting centrally in the brain and the spinal cord. Some stops the action potentials like LA. Then there are some that actually blocks the synthesis of your acetylcholine. Some blocks the release of the acetylcholine. Some blocks the calcium influx. Your magnesium, for example. Okay? Some blocks like your neuromuscular blocking agent blocks on the receptor itself. And actually some acts lower down in your muscle level as well. Okay, like ventrolin and things like that. So these slides you need to know. Some antibiotics can also cause muscle weakness, like blocking the transmissions. Yeah, it's asked in the exam before, but in SAQ, MCQ, I think it's too easy for you guys to think you'll ask in MCQ. Okay, in SAQ, they do ask you just list down drugs or classify the drugs that can actually cause muscle relaxations or weakness. So again, this is a summary of what we have gone through this now. Now, anybody can tell me what is depolarizing block definition? I'm sure you know that, just that you cannot put it into words. Okay, depolarization of the motor end plate immediately before the onset of muscle relaxations or muscle blockade. Okay, because it has a depolarizations before it becomes paralyzed. That's all. Okay, how does it occur? You need to know this mechanism. Okay, MEDEX, I'm not sure they'll ask you or not, but you need to know these two mechanisms, and these are, as anesthetists, people ask you, hey, how can I give such a patient paralyzed? Okay, because speculation of this student paralyzed, what happens because of these two things, activation of the voltage gated sodium channel next to your nicotinic acetylcholine receptor, far away from your end plate actually, and then this nicotinic acetylcholine receptor desensitization itself. Okay, it acts on the receptors and also those sodium voltage gated sodium channels that are at the peripheral of the motor end plates. Okay, you need to know about this thing, the sodium channel, the resting gate, and then the opening gate, the persistent open gate, and things like that. Why you need to know this? Because when you read about LA, local anesthetics, you come back to this again, voltage gated sodium channel. Alright? So what are the features of the depolarizing block? I'm sure in MCQ, if they ask you, you'll be able to answer, but if they ask you to write down in MCQ, it'll be tricky to score all the points because it's speculations. It has no fate, it has no post-tendon potentiation. You won't think about all this no, we think about all the yes. That's the problem. Okay? So how do you come about all this no is when you compare with the non-depolarizing block. Okay? And goes with you. Phase 2 block. How does phase 2 block happens? Anybody heard about phase 2 block? Anybody never heard of phase 2 block? So everybody heard of phase 2 block. It's because of two mechanisms. Either it's because of high single or a cumulative dose of succinylcholine, or a normal dose but the patient has a dysfunctional or lack of the concentrations of this plasma cholesterol. Okay. The features is consistent with non-depolarizing blockade. So you know the non-depolarizing block can describe the phase 2 block again. But whether it can be reversed or not by the anticholine esterase, it is unpredictable. Alright? So mechanism, you know, again, can be post-junctional, can be pre-junctionals, it can be desensitizations. The presence of fate, that's why I say maybe it's pre-junctional. So this is about pre-junctional nicotinic acetylcholine receptors. If you don't remember anything, just have to remember it has something to do with fate. Whenever fate is because of this, okay? Pre-junctional receptors. Then non-depolarizing block is mainly post-junctional actions, either by physically being blocked or actually a competitive antagonism binds on one of the alpha subunit leading to it cannot be activated. Okay? The features opposite of what we have for the depolarizing block. Okay. SAR, everybody gets it. Take deep breath, go straight, very simple. Okay? Again, I'm going to make it point form so everybody just remember the points. Okay? Alright. Number one is molecular size. The Bovang classified NMDA into two things, which is pachycuraric and also lactocuraric. By the name, pachy means huge and big and large, whatever you call it. Okay, lacto is small. Remember lactocirrhosis. Okay, all right. Lacto is small, pachy is big. When it's big, it's normally blocking. It's an antagonist. Right? It's not depolarizing. When it's small, it can bind to it, can stimulate and activates it, so it becomes an agonist, succinylcholine. Okay. So a bulky one will cause depolarization by blocking it, or non-depolarizing block by blocking it physically or blocking at the subunit. Okay, the metonium here, this metonium group is from the is the group that you found at the succinylcholine. This is your succinic acid. Do you know how to draw acetylcholine? This is acetylcholine. Okay, basically these two units of acetylcholine are hydrolyzed and form esterified by the metonium group. Okay, so actually it's very similar to acetylcholine. When it's similar to acetylcholine means it can stimulate your alpha subunit. This one is steroids. When you see A, B, C, D, it's steroid. So understand it? A, B, C, D is steroid. Okay, so there's a minor steroid group. So number one is the molecular size. That's all. Number one, SAR, molecular size. Number two, quaternary ammonium group. To bind to the alpha subunit, you need to have something very similar to the acetylcholine, which is the quaternary ammonium group. It's a charged ammonium group. Okay, so every muscle relaxants must have this in order to bind to the alpha subunit. Okay, this group over here, and also this group over here. Okay, must be a charge. Quaternary ammonium. Ammonium is a charge of 3. So quaternary means it has a positive, a proton there becomes a positive charge. And this positive charge also tell you one thing: it is not lipid soluble, it is water soluble. That's why your muscle relaxants are water soluble. Okay, the BD is very, very small because it's not lipid soluble. Okay, analogs of the acetylcholine, you need to have at least one in order for it to work as a muscle relaxant. And having more quaternary ammonium group will increase the potency. Do you want a muscle relaxant with high potency, or you want a muscle relaxant with lower potency? Depends on what we want, isn't it? But of course, we will prefer something with a lower potency, so we can use higher concentrations, more molecules, can compete with your acetylcholine to block the receptor more effectively. Alright. Okay, so you need something that has lower potency. Alright. Interonium distance. It can be asked in your primary MCQ. I don't think so. They will ask you in the next again. So it was okay, interonium distance is basically the distance between the two nitrogen, the quaternary ammonium ions. Okay, the distance, the optimum distance was actually found to be 14 angstrom, which is equivalent to 1.4 nanometer, which is equivalent to 10 carbon atoms. Know this number, this one, and this one. All right. Know the interonium distance. Only need to know this is optimum. Whatever is more will actually make it losing the potency. That's all. I'm sure everyone is very familiar with this reverse ester linkage of atracurium and cis atracurium, because this is what makes it very special. Non-organ dependent metabolism, so it can be hydrolyzed by your esterases, non-specific esterases, and also undergo Hoffman degradations. When I talk about these atracurium, Hoffman degradations, the next questions you're going to ask, adenosine. Okay, anyone never heard of this term before? No lah. Okay, good. Very good. So adenosine accumulations will cause CNS excitation and seizure. Have you seen one? No. Why? Because it binder those in human cortex. Unless suddenly you're going to give 2 ampules together or 3 ampules together to the patient. Activity of the A ring and the D ring, the Beers and Bridges group. Actually, this is something that's very long ago. I don't think so nowadays we ask, but if this happens to ask you, at least you've heard about this thing. Okay? Describe what is this Beers and Bridges group. Basically, very simple. It's the distance between the N and the O, okay? The nitrogen and the oxygen atom. What we're going to tell is that, this is applicable to only the amino steroid group of the amino steroid group of these neuromuscular relaxants. Your pancuronium, rocuronium, becuronium. Okay, so we have got A, B, C, and E ring. Come to ring, they always label them A, B, C, D, like opiates like that. So now we have the A ring and the D ring. The D ring always have these nicotinic acetylcholine receptors actions. So it's a 5.9 angstrom. And the A ring have the 4.4 angstrom, so it acts on the muscarinic action. Just remember these few things about this gear switches. Okay? Can. Want to go back? Or okay, can. Alright, good. Other thing about SAR, if you don't want to remember, then don't need to remember lah. But if you can remember, which is good lah. Okay? Alright, so classify. People like to ask you to classify drugs, isn't it? So classify muscle relaxants can be based on activity, can be depolarizing, non-depolarizing, chemical. These are Hausman thing again. Onset action, ultra short acting, short acting, intermediate acting, long acting. I'm sure everyone will be able to answer this question. Very simple. Okay. What are the non-neuromuscular actions of muscle relaxants? Have you ever thought of that? Muscle relaxant can cause something else besides paralyzing. Okay. It's asked in the exam as well. Okay. What are the non-neuromuscular actions? It causes autonomic effects in your cardiovascular system, basically in your autonomic thing that I mentioned just now, the A-ring and the D-ring, the gear switches rule. We talk about one is it acts blocks on muscarinic receptors. Blocking the muscarinic, anti-muscarinic effect, what will happen to the patients? Tachycardia. Right. But our newer drugs, pancuronium, procuronium, do not have such effect. Pancuronium still have a little bit, but not procuronium. Procuronium causes tachycardia by inducing pain. Alright. Release of histamine, serum, histamine, this thing. Okay. Next will be respiratory system. Again, some of the drugs will actually block the M3, some blocks at the M2. In general, again, we do not potentially vaguely induce bronchoconstrictions anymore. Okay, but it can actually cause bronchoconstrictions and also bronchodilation. Next will be these non-cholinergic actions. It's most serious. The side effects of these non-cholinergic effects is histamine release and also anaphylaxis. Okay, now we go to the pharmacological variables. Some things that I myself, before enter master, don't understand what is ED95 for muscle relaxants. Do you understand what is ED95 muscle relaxant? Is it the same when we talk about ED95 for Indonesian agents and microagents? It's different. It's different because the definition is a median dose that corresponding to 95% of the blockade of the single reach. Basically, it means that the dose of the drugs that is required to block 95% of a single reach. It's not blocking the receptors, it's not coming with it's more like the effects, okay, not in the populations. Right? We talk about MAC, and all those things is in populations, 95% of the population. But this one we talk about 95% of a single reach of adductor muscles following the stimulation of the arm. Alright, this is ED95 for muscle relaxant. Make clear of this. So onset. Just remember this table. If you can draw this table, you know what is onset, what is recovery index, what is the DO25, DO95. If you don't remember, I think people will ask you. Okay. MCQ, anything can be asked. Okay, recovery index. Then about pharmacokinetics. Again, pharmacokinetics, we learn about pharmacokinetics in general. We talk about single compartment model, two compartment model, three compartment model. Then we need to know how to apply these models into our drugs. That's why I mentioned just now when we talk about thiopentone, you don't compute yourself, you use a vessel reach group, vessel flow group, and those things, right? So for muscle relaxant, very simple, we just need to know these two compartment models. Why? Because of the low lipid solubility, high water solubility. VD is very low. So use two compartment models to describe the pharmacokinetics of your muscle relaxant and you're already. Because all your muscle relaxants are charged. Okay, so ask a patient to drink a bottle of procuronium, it won't have any effects. It does not cross the blood-brain barrier placenta. It won't cause paralysis in the baby. If you have been asked by some of these pediatric MO, they can ask you, hey, your muscle relaxant cause the baby to paralyze. Then you know that it's impossible. Okay, almost impossible to bind to lipids and plasma proteins in that time. That's why I say you need to know about your structures. Then you can argue. Okay? Otherwise you doubt yourself. Because it's written there, minimal lipid solubility, right? Then you say, I can go to the baby, right? Okay. So for pediatrics, when you use your muscle relaxant, you need to give a higher dose because of larger baby. Baby they have more water, your drugs is water soluble, so your baby has higher. Okay, makes sense to you, isn't it? When you understand what it means. So you need more frequent top up as well because of the more circulation, the higher cardiac output, better perfusion, all those things. So onset is faster because of high cardiac output. Okay. So elderly patients again. See, when it comes to pharmacokinetics, you know about the drugs already, you know what is the protein binding, then you go to your different populations. I talk about how many populations just now again? Obesity, pediatrics, obstetrics, Then you have the elderly patients, then you have the liver disease and the kidney disease. Then when you can apply into these few populations, you can guarantee a bit more, then you understand that you make it more confident. I can go for exam already. Okay? Alright. See, again, same thing. Alright? Renal efficiency and all. So, another question they can ask you, what will affect onset of actions? This is very important for muscle relaxation, isn't it? You want the patients to be paralyzed as soon as possible so they can put in the tube to prevent aspiration. So it is clinically very important to know what are the factors that affect the onset. So different routes of administrations. Can you give any other routes besides IV? Anyone can tell me? Have you given any other routes besides IV? Succinylcholine in IM. Can? Okay, rate of administration, sites of IV administration, and all these things. Absolutely. Site of IV administration is important as well. We give over the GARCI, give over the CDI, and give over the different, isn't it? Okay, so you need to have different expectations. Even though we say after you give 1.2 milligram of rocuronium, you can intubate the patient within 30 seconds. When you give it, okay, and how fast you flush it. So actually, those priming. Do you know what is priming? Priming is to give a dose of non-depolarizing muscle relaxants, then followed by a depolarizing muscle relaxant. Benefit from that, it can actually reduce the side effects, paralysis, and things like that. It can also fasten the onset. Okay, volume status of the patient's perfusions to various muscle groups. Right, because you want to paralyze a muscle. If the patient has muscle, have vessel constrictions because it's short, of course you expect them to have slow onset now. Okay. Pharmacodynamics, the patient's pharmacodynamics, basically the potency of the drug dynamics. Drug interactions, when patients on magnesium, for example, patients come seizure with PD, they are on medicine infusion, and then you want to paralyze them, you expect it to onset be faster? Should be, isn't it? Okay? So drug interactions with all the drugs that we mentioned earlier on, the drugs that can cause muscle relaxations will actually interact with our muscle relaxation. So this is some pitch. Okay, now we go to the drugs. The pitch where you're like, okay, succinylcholine. But I didn't put details. I tell you what you need to do. Okay? Preparations, you need to be able to describe. This is, I think, houseman level, medical student level, they can describe that it's actually a colorless solutions in a 2 ml bottle, and then it has 100 milligram for every 2 ml, so it's 50 milligram per ml now concentration. So be able to describe all these preparations. Okay, dose, what is the dose? What's the ED95? By knowing the ED95, you will know the dose. Same thing, if you know the dose, you can roughly come up with the ED95. So only 2 to 3 times ED95. Betul tak? Okay, so not much memorizing, but more to understanding. IM versus IV versus IVI. Then your pharmacokinetics, you need to know the ADEM, so you know the administrations, know metabolism, and also the factors affecting the metabolism. For distribution, nothing much different, isn't it? Because all are measurable. So very easy for this drug. Okay, on drug indication in patients with burn, spinal injury, know exactly the number of hours before you can give your muscle relaxants. How long after the injury you can give, or you cannot give, and also how long after the injuries or the incidents that you can give your muscle relaxant. Okay, these two figures can come out in your minutes. Okay, when you can give your succinylcholine again after burn and spinal injury, these two specifically. Need to know about NH, know about the sign and symptom of NH, how it occurs, the pathophysiology, okay, and then how do you manage the patients with the NH as well. This is expected when you are in the master program because you are going to become a specialist. You're going to need this until you finish your master, until you want to do your start, until forever if you choose this path. Okay? Alright, there's no ending. You need to know about NH, atypical plasma cholesterase. How do you analyze all those divocaine number and all those things? Okay, variations, divocaine number. Atracurium, you need to know that it's the first non-depolarizing muscle relaxants that is broken down in the bloodstream, not organ dependent. Okay, preparations, you need to know the dose. Again, ED95, onset and duration. By your clinical experience, you'll be able to answer this already, right? And then the isomers, the cis, atracurium and atracurium, what are the differences, advantage, disadvantage? Is there any disadvantage of cis atracurium? Can anyone just name one? Disadvantage of the cis atracurium over atracurium. Slower onset now. It's high potency, isn't it? Okay? But it's very good because lack of histamine release and things like that. So hormone degradations I mentioned just now already have to know the non-depolarizing and the atracurium. How about this? Okay. For MEDEX, you need to know succinylcholine, rocuronium, atracurium, atracurium, pancuronium if you can. Okay, because pancuronium is used in some of the centers. Okay. This mevalcurium, vecuronium, I will say vecuronium, you need to know why, because when you read about muscle relaxant, you read about reversal. In reversals, we talk about sugar MADEX. Sugar MADEX, we have vecuronium. Okay? So only one thing you need to read that, mevalcurium, so just read about it lah, okay. Alright, so as I mentioned, when you read about muscle relaxant, you don't only read about the drugs, you read about neuromuscular junctions, how the muscle contraction occurs. Okay. Subsequently, you go to the acetylcholine, you talk about the muscle relaxant, then you go to the reversals. Go to reversals, then you know about specific and non-specific reversals. When you talk about anticholinesterase, you know you need the anticholinergic drugs. So you read about anticholinergic drugs. Read about anticholinergic drugs, you read about OP also, organophosphate poisoning. Okay, so it's a continuous. Then subsequently, for those sitting for MCAI, you need to read about neuromuscular monitoring. And those who think that I'm okay with MEDEX already, I want to pass my part one now, that's my main focus. Read about neuromuscular monitoring. Know what is single twitch, what is TOP, what is PTC, what is DB. Apply these. I tell you how to apply these using rocuronium sugar MEDEX reversal. Okay? Don't just read about how much, how many hertz what the millisecond memorize all those details. Yes, you need to, but you need to have clinical applications. We are going towards clinical applications nowadays. We don't ask you a lot, like those irrelevant kind of things, So we ask you about, for example, preservatives to 444. We must have clinical applications. Okay? What will happen to the patient? What will happen to the drugs? Can you still use it, for example? What will be the color change? Or what's the cost? Okay? More like clinical application something. That's why, but you have to go through all the dry kind of theories first before you can really tell how to describe something, isn't it? You need to have the theory behind it. Okay, any questions? I'm sorry, I didn't go into details. I know that this is not what you expect.